Professor Antonio Ceriello. He is the president of ESC study group of diabetes and cardiovascular disease. He's also head of the research department on diabetes and cardiovascular disease of the Institute of GIBABS, Barcelona, Spain. I start with some introduction about the role of cardiologists in management of type 2 diabetes. I said that, in fact, there is an emerging concept that now may be the time for cardiologists to start thinking seriously for prescribing antidiabetic drug. Fortunately, until now, most cardiologists have not considered this as a part of their job description. I said that, Professor Antonio, you will answer the question now, the question why cardiologists shouldn't initiate diabetes treatment. Could you please start your talk?
Thank you for the very nice introduction. And also let me say that what I'm going to present you, of course, is my personal view, is not any society view, just to be clear. These are my conflict of interest. So we learned in the last years from the CVOT trials that the new classes of anti-hyperglycemic compound, particularly the SGLT2 inhibitors, GLP-1 receptor agonists, can really give a benefit in preventing cardiovascular complications and also somehow kidney complications in diabetes, at least in type 2 diabetes, for whom we have evidence. And you know that because these CVOT trials were arriving in different periods, in different years, we had several guidelines which were trying to really follow the news, and many of them were trying really to give us some suggestions on how to manage this, the effect of these drugs on cardiovascular disease management. One of the most recent guidelines is the guideline coming from the joint work between the European Society of Cardiology and the ESD. I had the honor to be part of this board, and one of the main, there were some interesting news that I'm going to share with you. The first was not really new, but the recommendation was that when somebody was, I'm speaking about a patient with type 2 diabetes, and this patient already has established cardiovascular disease or is at high, very high cardiovascular risk and already treated with the metformin, the recommendation was that a second step to add an SGLT2 or an GLP-1 receptor agonist. If not, in this situation of cardiovascular risk, you have to continue with metformin and, of course, choose another drug if A1C is not at the target. And in this case, you have a wide range. You know, today we really have a wide range of drugs which can be used to control glycemia. Somehow, this position was shared with the new ESD ADA algorithm. You know that almost every year, ADA, the ESD are updating the algorithm about the management of hyperglycemia and diabetes. And after just a few months, the publication of the European Society of Cardiology Guidelines, the ADA algorithm was published, and I have to admit that somehow, in some aspect, it was really even more advanced than the ESC guidelines. Why? Because in people already treated with metformin and at a very high risk for cardiovascular disease, the suggestion was, and this was even more precise than the ESC guidelines, to use an a GLP-1 receptor agonist in the case of an established cardiovascular disease or high risk for cardiovascular disease, or to use an SGLT2 inhibitors in presence of heart failure risk of heart failure, or when the chronic kidney disease was predominant. And there was also another important step ahead, that the recommendation in this algorithm was to go through this way independently from the A1C target, meaning, anyhow, if a patient with type 2 diabetes is high risk for cardiovascular disease, heart failure, or kidney disease, independently of the A1C of the A1C level, add this one of these drugs to this treatment. Well, somehow this supposition, the ADA is the algorithm, the ESC guidelines were somehow superimposable. Why? The situation was completely different about the drug-naive patients. Because in this case, the position of the European Society of Cardiology was a little bit provocative, and let's say new at that time, because the suggestion was not to start with the metformin, but to start directly with an SGLT2 or GLP-1 receptor agonist if somebody is a high risk for cardiovascular disease. Of course, metformin, the monotherapy, could be the first choice in the case that the situation is under control. The situation for cardiovascular risk is under control. And this position was substantially different from the position of the ADA as ESD algorithm. Because again, you see that even suggesting to add a drug which can prevent cardiovascular disease in people at high risk for cardiovascular disease, independently from the target of A1C, the ADA algorithm was still there in suggesting metformin as first-line therapy. Why? I have to say that what do we know about metformin and cardiovascular disease? Some evidence are in favor of cardiovascular disease protection by metformin, but also I will show you that there are some recent meta-analyses which must be considered. And also one issue was in favor of suggesting metformin as background therapy, even using an SGLT2 or a GLP-1, that in the majority of the patients, including the CVOT trials, metformin was as background therapy. So you cannot discriminate between the pure effect of these new compounds or the combination with these compounds and metformin on cardiovascular outcome. Well, which are the evidence in favor of cardiovascular protection by metformin? We have only one evidence. This evidence is coming from the subgroup analysis of the very old trial UKPDS. You see that this subgroup of the UKPDS treated the metformin because being a little bit overweight, there was a prevention of myocardial infarction, which lasted even in the follow-up. You know, the UKPDS has a very, at least 10-year post-trial monitoring. However, if you see the number of people included in this post-hoc subgroup analysis, you see that is quite small in terms that let's say there are no more than 350 people in this study. So any consideration about the protective effect of metformin was coming from this small group of people in UKPDS and based on 39 events, 39 myocardial infarction. On the contrary, we have some recent meta-analysis showing, I'm showing one in favor and one in against the effect of metformin on cardiovascular disease. On your left side, you see one of the meta-analyses showing any beneficial effect of metformin preventing cardiovascular disease in type 2 diabetes. There is only one meta-analysis in favor of metformin, but in not only in my opinion, but the experts of meta-analysis are really questioning the value of combining randomized control trial with real-life evidence. And this was the case of this meta-analysis. So let's say that scientifically, this meta-analysis does not seem very well conducted, and also you cannot just merge real-life evidence and randomized control trials. They are completely different and cannot be used for to merge to be emerging for a meta-analysis. But the most intriguing question is, okay, but metformin was always as background therapy in the CVOT trials, but we have now evidence questioning this, the need to have metformin as background therapy for the prevention of cardiovascular disease shown by these new compounds. Because you see that in this, for example, this study published a couple of years ago, that the empagliflozin in the EMPA-REG outcome worked anyhow, independently from the presence of metformin. On the contrary, it looks that when metformin was in the background therapy, the effect of the empagliflozin was somehow decreased. So it was less beneficial that when it worked, it was given alone. And similarly, also, these results is coming from the Canvas trial. Again, the effect of having metformin as background therapy was not reducing the benefit of using canagliflozin, particularly for the reduction of cardiovascular events. And more recently, the same has been demonstrated for the CVOTS trial using dulaglutide. So the story that metformin is needed as background therapy to amplify or to get the benefit of this new drug, honestly, is not supported by the data. Why I needed this introduction, probably you already knew, because some years ago, let's say more than 20 years ago, the American Heart Association published a very intriguing and, let's say, provocative statement. And in this consensus, in fact, the American Heart Association declared that diabetes, in fact, is a cardiovascular disease. So there is no role for experts in metabolism, endocrinologists, diabetologists, because at the end of the day, for the cardiologist, diabetes is simply a cardiovascular disease. So this is the most important aspect of this disease. And I think that we have to look at something that never, in my experience, cardiologists were really looking for, and this is the optimal glycemic control in their patients. This was never handled by the cardiologist. And we know from UKPDS that the beneficial effect of a strict glycemic control, particularly in primary prevention, because in UKPDS, okay, we needed a lot of that time, more than almost 30 years, but this was clear that an intensive control of glycemia can reduce the risk for cardiovascular disease. And this is why probably we got this difference in the final outcome of the UKPDS and the other well-known interventional trials, meaning the advanced accord VADT. In the UKPDS, the treatment, intensive treatment was started almost at the beginning of the disease, while you see in the other trials the disease was already well established and the intensive treatment started after many years. But what is more important, in my opinion, is the question, is a good glycemic control helpful in preventing a further cardiovascular event in people who already had the cardiovascular events? It seems that this is the case. Even the 3 trials were probably failed to demonstrate this, and we can discuss if you want why. Probably the amount of hypoglycemia was too high to, this was, let's say, decreasing the effect of intensive glycemic control on a good outcome. Anyhow, we have some meta-analysis. I'm showing one probably the most interesting and important. This meta-analysis published by Ray, showing that in people with already had the previous cardiovascular events, in intensive glycemic control can help to prevent a further event. And this is not related to also to have to increase the total mortality, as was in the ECHO trial. So the message is good to have a optimal glycemic control, to also to prevent cardiovascular disease, also in people with the previous cardiovascular events. Why probably in the 3 trials, the outcome of intensive treatment or intensive glycemic treatment was not achieved in terms of a benefit of cardiovascular events, because it was well known that there was a huge increase of severe hypoglycemia associated particularly with intensive treatment. So the physicians were treating so intensively people that, okay, on one side they were really well controlling A1C, but on the other side, the price paid for this was a huge amount of hypoglycemic episodes. And let's conclude that today, when we speak about a good glycemic control, the story it's very, very complicated. It's not just to decrease A1C or fasting glycemia. I summarized this in a paper published last year, in editorial published last year in Diabetes Care, making an update on what means a perfect management of hyperglycemia today. It means not only to control A1C and fasting plasma glucose, but also to control short-term and long-term glucose variability, to have how much is possible people in the range of normal glycemia during the day, to avoid the peak of postprandial hyperglycemia both at 1 hour and at 2 hours, to avoid hypoglycemia. And this is even more complicated if you have hypoglycemia, to rescue from hypoglycemia, avoiding the production of hyperglycemia. So it's very complicated today to the management, optimal management of hyperglycemia, which in my opinion is almost neglected by cardiologists. And so to use some drugs just to decrease hyperglycemia, probably to decrease, the risk for cardiovascular disease, which seems to be the more easy approach today, is not completely true. We need to harmonize the cardiocentric and the glucocentric view of diabetes management. It's not enough to just give some drugs that you believe, okay, this way I can have extra benefit, I can prevent cardiovascular disease, avoiding the optimal glycemic control, that which not only is also contributing to cardiovascular complication, but particularly is the key risk factor for microvascular complication, meaning retinopathy and particularly neuropathy, which at the moment does not have a specific treatment. And this is why we have recently suggested that probably the best way is to start immediately with a combination. And we have the support from coming from this evidence and that starting immediately the combination is more able to preserve beta cell function. But on the other hand, also if you start immediately with the combination using a GLP-1 receptor agonist on SGLT2 inhibitor, you can also get a major protection against cardiovascular risk. And also you can get a good glycemic control, because at the end of the day, we cannot forget that these two classes are very good also in decreasing glycemia. So they were born in this way, and they are still working as good hypoglycemic agent. So in conclusion, cardiovascular disease is the leading cause of mortality in diabetes. However, we cannot forget how important it is also to avoid the microvascular complication of this disease, and how an early and continuous optimal glycemic control remains the best strategy. Therefore, it seems that it is time to harmonize both the gluco and cardiocentric approach as the best strategy to reduce the burden of all kinds of complications of diabetes, micro and microvascular complications. My naive question is this aspect manageable by cardiologists? I believe honestly that today, even we are cooperating a lot. You saw I was cooperating with the European Society of Cardiology in developing the new guidelines of the diabetes cardiovascular disease management. They are very interesting in diabetes, but some aspect of diabetes management, particularly the need for intensive glycemic control and how to reach today an optimal perfect glycemic control, is far away from their experience. Thank you very much.
Thank you, Professor Antonio, for your clear, convincing answer. Cardiologists shouldn't initiate, and I add to follow anti-diabetic therapy of diabetic patient. In my own opinion, the most important barrier to cardiologists to start or initiate anti-diabetic medicine is the lack of the deep, digested, practical knowledge of anti-diabetic drugs, how to treat the dose, how to follow the other complications of the disease itself. I imagine that the knowledge of cardiologists about the antibiotic drug is similar to our knowledge as internist and cardiologist about anti-arrhythmic drugs. So I think it's a clear answer up till now. Cardiologists shouldn't initiate or follow the anti-diabetic drug itself. My own question, before I give the chance to the other to ask, do you think, Professor Antonio, that the inertia of diabetologists and internists to start or initiate the new anti-diabetic drug with cardiovascular proven benefits, this is the motivator to cardiologists to take the upper hand in the management of type 2 diabetes?
No, this is our fault, let's say, as diabetologists, our inertia. I have to be honest, we have data there, you know, that these new drugs are not used as they deserve to be used. And this is not good for our patients. On the other hand, honestly, because the cardiologists very rare are engaged in the so-called primary prevention, meaning they will see patients already with a cardiovascular disease. So if we want really to get the best, we need to start as soon as possible this drug to prevent the appearance of cardiovascular disease, and not to treat the cardiovascular disease with this new drugs.
My last question about the expected role of the new drugs, new anti-diabetic drug with the cardiovascular proven benefits for the primary prevention of cardiovascular disease in non-diabetic patients with multiple risk factors.
Yeah, we have a very intriguing data, at least for the SGLT2, about prevention of more specifically of heart failure, because this was the primary outcome of the two studies with empagliflozin and dapagliflozin. But you know that as a secondary endpoint, also one showed that in this way that they also reduce cardiovascular mortality in non-diabetes. And this is why cardiologists at the moment are so interested in these drugs. The problem is, okay, they also reduce glycemia. They can induce some hypo. Are they able to understand also this aspect and not just to give the pill and say, okay, you are protected against cardiovascular disease, but who knows what happens about glycemia, even non-diabetes, sorry.
Thank you. Is there any question from the floor? Much thanks, Professor Antonio, for your elegant talk. Thank you.
Bye. Thank you very much.
Thank you. Thank you.